on the management of Ankyloglossia in children. And get the picture off the screen here. This publication, sorry, my slide is not advancing. Oh, here we go. So this publication came out last year, and it was expert panel of pediatric otolaryngologists, about 14 from across the country. And they targeted children ages 0 to 18 years of age. And the panel distilled their opinion into these clinical statements, the standardized consensus statements. They used methodology consistent with coming to consensus to come up with these statements. They came up with 89 statements. I will not go through all 89 statements, but 41 of them met consensus and 17 were near consensus and 28 did not reach consensus. And the lack of consensus on the statements likely reflected knowledge gaps and lack of evidence regarding the diagnosis, management, and treatment of ankyloglossia. I just wanted to mention there were 106 references, including otolaryngology, dental, and lactation literature. So I think they did their due diligence and looking at the current information that is available, not just in the otolaryngology community. Despite this being a panel of otolaryngologists, they did look at dental and lactation literature to complete the consensus. To start, a little background. Sorry, my slides aren't advancing. Technical issues. There we go. So just some background on tongue-tie or ankyloglossia. The earliest cases were reported back in the 1600s and surgical textbooks showing an infant frenulum being cut with scissors back in those days. And evidence or stories have been told too that midwives back in the 18th century would keep their fingernails long to lyse a frenulum at the birth of babies back in those days. I think for those of you who've been practiced for a while, you probably noticed a significant increase in the diagnosis of ankyloglossia in newborns and the increased rate of frenotomies as well. And I've been in practice in 25 years, and we definitely saw an increase. And I'll talk to the group later too about lip tie management as well. We saw a surge in lip tie diagnoses as well, corresponding with the increased diagnoses of the tongue-tie, lingual tongue ties. There have been Cochrane analyses performed on frenotomy in infants showing reduced nursing mother's nipple pain in the short term after frenotomy, but no other consistent positive effects on infant breastfeeding. There's also been systematic reviews showing insufficient data for assessing the effect of frenotomy on non-breastfeeding outcomes that may be associated with ankyloglossia. And these are a couple of references that I pulled from the consensus statement. Just some background on ankyloglossia. The incidence in newborns is about 2.8 to 10.7%, with the noted increase in the recent years, as mentioned. The reason for this increase may be due to the focus on the benefits of breastfeeding in infants, as well as the increased awareness that ankyloglossias can negatively affect breastfeeding in infants. And also an increase in the number of lactation consultants who identify infants with ankyloglossia that probably plays a role in this issue. Also, our young tech-savvy individuals are increasingly going to social media and websites for information that's available on tongue-tie. We also have an increased number of medical practitioners, particularly the dental folks who treat ankyloglossia in the community as well. So these are some of the initial statements reaching consensus on ankyloglossia. The first one is just the basic definition. So ankyloglossia is a condition of limited tongue mobility caused by restriction of the lingual frenulum. And some practitioners have described ankyloglossia as being anterior or posterior. And for those that do so, Anterior Ankyloglossia refers to a lingual frenulum that extends to the tip of the tongue or near the tip of the tongue that restricts the tongue mobility. So that's your typical tongue tie in the infant. In some communities, they mention infants and children are being overdiagnosed with ankyloglossia, and in some communities, a significant number of children are having unnecessary surgery for the lingual frenulum. There is actually no consensus on the definition of a posterior tie. Some will say that the frenulum inserts in the posterior portion of the tongue, or the frenulum is a submucosal tethering of the tongue. So for example, in the picture at the bottom, this might look like a normal frenulum to some, but on palpation, you might feel a band underneath the tongue. That would be, in my definition, what I would consider a posterior tongue tie. Some of the panel members did not feel that the posterior tongue tie existed as an anatomic entity and that the term posterior ankyloglossia should be abandoned. At this time, there is no preferred Ankyloglossias grading system. There's a system called Correlos that looks at the type of frenulum, whether it be posterior or anterior, and then the Hazelbacker and Bristol systems look at not just anterior, posterior, but also the functionality of the restricted movement of the tongue and those scoring systems. So as far as statements that reach consensus for ankyloglossia and breastfeeding, they mention that breastfeeding problems are common in newborns, and evidence shows that anterior ankyloglossia is a potential impact on breastfeeding in infants. And maternal pain and poor infant latch can be caused by ankyloglossia, but these symptoms can also be present with other etiologies of breastfeeding difficulties. So when you're evaluating these kids, you should do a careful history, including the lactation history, do a physical exam, inspection, and also palpation, I think is really important when assessing these children. They mentioned the importance of the maternal and infant breastfeeding dyad, and this should be recognized as a vulnerable patient population, so we should take care to ensure adequate support services, education and counseling, and share decision-making about these children. They mentioned that if a woman stops breastfeeding due to issues with feeding, that sometimes it's hard for them to get back into breastfeeding and the benefits of breastfeeding. They mentioned that it's ideal if the infant be seen by a lactation consultant prior to consideration for lingual frenotomy. Just to get back to breastfeeding and ankyloglossia, some of the associated symptoms due to ankyloglossia include nipple pain with nursing, irritation of the nipple skin, and a shallow pore latch. Again, mention obtain a good lactation history. If the mom had no issues with breastfeeding with previous infants, look at the length of and frequency of breastfeeding sessions, formula supplementation or pumping, and lactation support utilization. So you want to assess maternal factors, and this may be where the lactation consultant comes in, looking at comfort with feeds. It's pretty common to be uncomfortable during the first few weeks of feeding, but look at nipple anatomy, core positioning, and support of the breast while feeding the baby. The maternal milk supply can be an issue, and of course, infections. Also, you want to assess infant factors like prematurity, which may affect the suck and swallow coordination. Abnormal palate, maxillary, and mandibular development may also be factors in establishing a good latch. Neurologic disorders resulting in low tone, for example, may have an impact on feeding, as well as issues of upper airway obstruction in infants. So these are some statements that reach consensus on frenotomy indications and consent. Where I have the red highlights, I placed those. Those were not placed by the authors. I just thought those were the high points that I wanted to touch on with you folks today. So when you're assessing these children, you want to evaluate other head and neck sources of breastfeeding problems like nasal obstruction, airway obstruction, reflux issues, and craniofacial anomalies. And contraindications include neuromuscular disorders, hypotonia, and coagulopathy. Complications include hemorrhage. So when we do these babies in our at Lurie, we apply a little piece of gauze with a little Afrin, which is a vasoconstrictor on the site right after the procedure to help with vasoconstriction and limit bleeding. Airway obstruction considerations. There's been reports of concerns of doing frenectomies in kids who are micrognathic or retrognathic and resulting in the tongue kind of collapsing back and obstructing the airway more. Injury to salivary structures, oral aversion, and scarring. The frenectomy site can rescar down, although it's rare in infants in my experience. Informed consent should include a statement of possibility of failure to improve breastfeeding. As mentioned, there could be other reasons that can be impacting why the child is not feeding well at the breast. Breastfeeding difficulty and maternal pain may resolve without surgical treatment. So you should counsel on non-surgical options of observation, a lactation consultation if one has not already been completed, as well as a speech-language consultation, particularly like in an older child who has issues. Benefits include relief of maternal symptoms from the procedure, less pain, and maternal reported improvement in feeding overall. Some additional statements on frenectomy indications and consent. So as mentioned, frenectomy is not always effective in relieving maternal pain and breastfeeding difficulties because there may be other reasons for the breastfeeding difficulties. Pain and feeding efficacy in the presence of ankyloglossia is more likely to improve though with lingual frenectomy or surgical treatment. And they mentioned that it's important to perform as soon as possible after diagnosis in the infant with breastfeeding problems not improving with conservative management. Again, this points to the issue that moms don't always go back to breastfeeding if they have some issues at first and go back to bottle feeding. It's not necessary to perform in an infant with little to no tongue restriction and their mobility to prevent a future feeding disorder that we can't predict, and not necessary to perform in an infant with little to no restriction in tongue mobility to prevent future speech disorders. This comes up quite a bit where we see babies with fairly significant tongue ties who aren't really having feeding issues or nursing issues, or they're bottle fed, so it's not as apparent that there's an issue. And I think this is one of those areas where it's just a good conversation and shared decision making about the benefits of releasing the frenulectomy or the frenulum now in a newborn versus later in life, where in our case we often have a child undergo a brief general anesthetic. As far as the frenectomy procedure goes, the procedure itself is generally safe and well tolerated. Topical anesthetics are not recommended these days prior to infant frenectomy, and injectables are not recommended as well. I used to use the topical viscous lidocaine for the procedure. It really gave the babies a bad taste in the mouth, and it made it more difficult to feed afterwards, I felt. So nowadays, I think we go to the oral sucrose, the sweeties, and this has been shown to decrease the pain response in infants who are undergoing procedures like frenectomy. They use it quite a bit in the NICU, as many of you may know, prior to procedural things. There is insufficient evidence to support claims that one technique of frenectomy, such as a laser versus a cold technique, is superior to the other techniques. These are the items at the side are the items that we use to clip a frenulum. The top is what's called a groove director that's inserted around the frenulum to isolate it from the other structures of the tongue and the floor of mouth, and then we simply clip the band. Then we do a finger swipe to open things up, and after the procedure is completed, you usually see a little diamond underneath the tongue in the muscular fibers of the tongue underneath, and that way you kind of can confirm that you've done a complete clipping. After frenectomy is performed for ankyloglossia, there's no evidence to support a post-procedure care regimen like stretching and finger swipes and elevating the tongue on the parent side. That's not been shown to be beneficial. I think particularly in newborns who are actively feeding and engaging in pacifiers and whatnot, their tongues are so active and mobile that it's very, very uncommon to see any issues with retethering or rescarring of the tongue. As far as older kids go, Probably a little bit more controversial. The consensus panel did not feel that the Ankyloglossia typically affects speech. I think there are certainly cases where it may be more clearly associated than others. They do encourage a consultation with the speech pathologist prior to consideration for frenotomy in older kids undergoing ankyloglossia for possible speech concerns. And ankyloglossia may cause some social mechanical issues like difficulty licking the teeth and lips and a gap in the central incisors, as well as a sense of embarrassment. I've certainly been, laughed about cases where maybe the child or the older child wasn't able to kiss as easily because of it. So the social and mechanical issues, some of those kids will experience an improved quality of life by undergoing the procedure, so it may make sense in those situations. There's no real maximum age for the procedure. I've done teenagers in the office. There's also no preferred surgical method for the older patients as well for the frenotomy. As far as the labial frenulum, I think this has become much more of a trend over these past years. It just kind of popped up all of a sudden and became a very common diagnosis. And I think probably 6, 7, 8 years ago, I was coming across more patients referred for this diagnosis and clipping a few here and there. But the presence of an upper lip frenulum is normal in an infant. There's also grading scales for upper lip frenulums, but these are again not consistently used, and there's not a standardized approach that the consensus panel thought was appropriate. And basically, there's an unclear relationship to breastfeeding difficulties and an upper lip tie. There are reports where babies have benefit from clipping, but it's not been widely accepted as a remedy for nursing issues. In some communities, upper lip tie is being overdiagnosed, and the upper lip frenotomy will not prevent the occurrence of the gap between the front teeth. So the next over to the side are the statements not reaching consensus for the upper lip tie. So they mentioned that when an infant has tongue and lip ties, it's not really necessary to say, let's clip the tongue first, see how the child does, and then come back and clip the tongue. That did not reach consensus. I think some, specialists will clip both at the same time. Some will stage it like this, but there's not a consensus on the appropriate management in that sense. There's no evidence suggesting a positive impact on breastfeeding outcomes. An upper lip frenulum that restricts ability to evert the lip during feeding is pretty normal. So I know I've heard that that's an issue that when kids have been sent to me with upper lip ties, that they can't fan the lip out to get a good latch. There are potential benefits of release in select patients, and symptomatic tie identified when lip is restricted from flaring around the breast in a manner that facilitates breastfeeding. When an infant with feeding issues has a tongue and lip tie, they should be released concurrently. Again, these are statements that did not reach consensus. So I think with mutual decision making with the family, you have to come up with management strategy for patients with both what you would consider a lip and a tongue tie in these patients. Some other statements that did not reach consensus on infant frenotomy. Office setting is preferred location whenever possible to avoid general anesthesia. I think the newborns we generally do in the office, and it's safe and very effective. We typically like to keep it to children under age 3 months in the office-based setting. There may be some exceptions to that, but that's our general rule of thumb at Lurie, just FYI. After the procedure, it's best to observe the child actively breastfeeding and to answer questions about any issues when noted. That did not reach consensus. We do watch our patients after the procedure here at Lurie. I think it gives us time to just ensure that the mom is comfortable with feeding. And also I like to make sure that there's no residual bleeding from the site after the procedure. And I think it just builds a good doctor-patient relationship with the families to spend a little time with that family. Lingual frenotomy can be performed at any age in the office or operating room based on clinical experience and patient preference. So our older kids, we tend to take to the operating room for these procedures. Like I said, I've done some teenagers in the office who can tolerate a local anesthetic because they would use a local anesthetic in a bigger kid. Informed consent should include a discussion of rare complications. I think it's appropriate to discuss the common complications, the potential for injury to the salivary structures, lingual nerves, and retethering of the tongue over time. It did not reach consensus that frenotomy for posterior ankyloglossia is not as effective in resolving breastfeeding difficulties. I don't think it's really understood the role of the diagnosis of posterior ankyloglossia in feeding. I've certainly treated patients with what I consider posterior ankyloglossia who've done quite well afterwards with feeding. So I think you just have to select the appropriate patients when moving ahead with frenotomy in those kids. Lingual frenotomy in an infant with a severe tongue restriction, even without breastfeeding difficulties, may prevent the need for general anesthesia if frenotomy is deferred to a later age. I think this is always tricky because, like I said, in the older kids, if we're doing a frenotomy, we do have them go off under anesthesia. So some parents would prefer not to have to address that later in life if there were to be a speech issue. Again, the consensus didn't feel that ankyloglossia was an impact on speech issues, but I think we certainly have had patients that have seen speech therapists who do benefit from release of the tongue tie. So this is a bit of a gray area. And some of the statements that reach near consensus is after frenotomy for posterior ankyloglossia, there is no evidence to support a standard post-procedure care regimen. That's the same with anterior ankyloglossia as far as like tongue stretching and things. And follow-up should be available to assess for complications or lack of improvement. We, of course, are happy to follow up on our patients if they have any issues, but we usually just ask them to call if they have questions. And the ideal age for frenotomy in infants with ankyloglossia and breastfeeding difficulties is less than 3 months of age. I mean, like I said, we prefer to do these procedures in the office in children and newborn babies under 3 months of age. And the younger, the better. I think the membrane is thinner and less vascular, likely to bleed a bit after the procedure. Most of these babies with a little local pressure, the bleeding isn't a significant issue. I've had a couple that we've had to monitor them for a little bit more time in the office to ensure that there was no concerns going home, but most babies do just fine. In conclusion, so the intent of the consensus statement were to promote appropriate evidence-based care of the infant and child with ankyloglossia and upper lip tie. There are marked differences in opinion, of course, regarding the controversial topics like posterior ankyloglossia and a lip tie. And frenotomy in infants with ankyloglossia can lead to improvement in breastfeeding, as discussed. But not all infants with ankyloglossia need to have a frenotomy because there's other reasons for breastfeeding difficulties. And the level of evidence for intervention for the maxillary frenulum and the upper lip tie is poor at this time. So the statements are expected to just basically improve the understanding of the controversies surrounding ankyloglossia in children and lead to more family-centered care in our patients.